You are 22 years old, and you have just arrived in London with 14 shillings, a letter of introduction, and a name no one here recognizes. The letter is from your father's physician in Bristol, a man whose handwriting trembles and whose name carries no weight in this city. You carry it anyway, folded in your breast pocket, pressed flat by your hand each time you feel uncertain, which is often. You are a dresser at St. Bartholomew's Hospital. That is what they call you. Not a surgeon. Not a student. A dresser. Your job is to change the dressings on wounds, to hold limbs steady, to carry instruments from the cabinet to the operating table and back again. You arrive at 6 in the morning. You leave, if you are lucky, by 9 at night. You are paid nothing. You pay them £4 a year for the privilege of standing in the room. The operating theatre is a wooden amphitheatre built above the wards. Sawdust covers the floor. Not for comfort. For the blood. You learn this on your second day, when a man is brought in with a compound fracture of the femur and the surgeon, Mr. Liston, takes 45 seconds to remove the leg. You count. Everyone counts. Speed is the only mercy available. The patient screams. You hold the shoulder. You do not flinch. You learn not to flinch. This is the first thing the system teaches you. Your face must remain still. Your stomach can turn. Your mind can fracture quietly into something you will not examine until much later, in the small room you rent near Smithfield, lying on a thin mattress, staring at the ceiling. But your face must be still. The smell of the ward is something you eventually stop noticing. Carbolic acid has not yet arrived. Joseph Lister is still a student somewhere. In 1842, the smell is gangrene and unwashed bodies and the particular sweet rot of infection settling into muscle. The ward holds 40 men in 20 beds. Some share. None complain about it. Complaining implies an expectation of better, and these men, laborers, tradesmen, the poor, have long since learned not to expect better. By your third year, you are a house surgeon. You have passed your examinations at the Royal College of Surgeons, 2 oral interviews, a demonstration of technique on a cadaver, a fee of £22. You can now perform minor operations unsupervised. Lancing abscesses. Setting simple fractures. Removing surface tumors. The supervising surgeon, Mr. Aldridge, reviews your casebook once a week and signs it without reading it. This is how oversight functions here. It is procedural. It is not attentive. You perform your first amputation alone in the spring of 1845. The patient is a woman, 34 years old, a seamstress. Her right hand has been crushed in machinery. 3 fingers are already gangrenous. You take the hand at the wrist. She is conscious. 2 orderlies hold her arms. A third holds her legs. She does not scream the entire time. She makes a low, sustained sound, something between a moan and a hum, and when it is over she goes very quiet. You tie off the vessels, pack the stump with lint soaked in turpentine, and write in your casebook, amputation of right hand at wrist. Duration, 3 minutes, 10 seconds. Patient tolerated procedure. Tolerated is the word they use. You use it too, now. It means, did not die on the table. It means nothing more than that. In December of that same year, a paper arrives from America. A dentist in Boston has used ether to render a patient insensible during a tooth extraction. The report circulates through the hospital with the speed of genuine astonishment. Within weeks, Mr. Aldrich performs the first ether-anesthetized amputation at Bart's. You assist. The patient, a man with an infected leg, 40 years old, a bricklayer, lies still. He breathes. His chest rises and falls with the rhythm of someone asleep. You have held down perhaps 200 patients in 3 years. You have felt the animal force of a human body resisting what is happening to it. You have felt wrists bruise under your hands. And now the man on the table simply lies there. When it is over, he wakes slowly, confused, and asks if it has begun yet. Mr. Aldridge tells him it is done. The man begins to weep. Not from pain. From relief he cannot quite articulate. You stand at the edge of the table and feel something shift in you, a recognition that what came before was not simply the absence of something better, but was its own specific cruelty, tolerated because it had always been tolerated. You do not say this aloud. You write it nowhere. You return to the ward. By 1850 you are a consulting surgeon, attached to the hospital and to a private practice in a terrace house in Bloomsbury. You see private patients on Tuesday and Thursday mornings. They pay between 1 guinea and 3 guineas per consultation, depending on what they require and what they can afford, though in practice you charge what you judge they are willing to pay, which correlates closely with the quality of their furniture. The hospital work pays nothing directly. The reputation built there makes the private work possible. This is the arrangement. It has always been the arrangement. The hierarchy at Bart's is clear and rarely spoken of directly. At the top are the consulting surgeons, men who have held their positions for 20 or 30 years, who appear on ward rounds twice weekly, who lecture to the students in the theater on Mondays and Fridays. Below them are the house surgeons. Below them are the dressers. The system is not designed to be climbed. It is designed to be endured until a position opens through retirement or death, at which point you may apply, and if you have not made enemies in the wrong places, and if your casebook shows a mortality rate that does not embarrass the institution, you may be considered. There are unspoken rules. You do not contradict a consulting surgeon in front of students. You do not discuss your mortality rates with patients. When a patient dies of erysipelas, the red wound infection that moves through a ward like weather, you write died of constitutional weakness or died of exhaustion following injury. This is not dishonesty, precisely. It is the language the system has developed for facts it has not yet decided how to address. You use the language. Everyone uses the language. After a while, you stop noticing you are doing it. You are aware, by now, that the gap between what you were told this work would be and what it actually is runs through almost everything. You were told you would relieve suffering. You do relieve suffering, sometimes. You were told you would advance knowledge. You do keep casebooks. You do present at meetings of the Medical and Chirurgical Society, twice, on the topic of outcomes following amputations at different levels. But mostly you manage the ward, the students, the waiting list, the families who appear at the hospital. Gates asking after someone who arrived 3 days ago and has not been heard from since. The waiting list for elective procedures is 8 weeks. For most of the people on it, this means continuing to work in pain, because they cannot afford not to work. Your wife's name is Eleanor. You married in 1847, when you were 27 and she was 23. She knew what she was marrying. Her father was a physician in Norwich. She had grown up around the hours, the absences, the way a man returns from a ward and sits at the dinner table present in body but elsewhere in attention, processing something he will not describe. You do not describe it. You have tried. The difficulty is that the events of a day at the hospital do not translate well into dinner conversation. The particulars are too specific, too physical, too far outside the range of experience available to a woman who has spent the day managing a household in Bloomsbury. And so you summarize, when asked. Busy. The usual. Nothing out of the ordinary. After some years, she stops asking. This is not coldness. It is accommodation. The marriage survives on accommodation. You have 2 children. A son, born in 1849, who will become a solicitor. A daughter, born in 1852, who will marry a clergyman in Wiltshire. You are present for neither birth. You are at the hospital for the first and attending a private patient, a man with a bladder stone, a member of Parliament, for the second. You are told of both by letter, which is how you learn most things that happen at home. You keep the letters in a drawer. You do not reread them. There is a particular form of rationalization you develop across these years, as most men in your position develop it. It goes, the work is necessary, and if I do not do it, it will be done by someone less careful, less skilled, less attentive to outcome. This is probably true. It does not make the cost of doing it smaller. It simply makes the cost easier to carry, which is a different thing. In the autumn of 1863, a young man is brought into the hospital with a wound to the abdomen. He is 20 years old. He has fallen from scaffolding near the new Victoria embankment works. The wound is not the worst you have seen. You operate. The technique is sound. The wound closes. On the third day, infection sets in, not in the wound, but internally. Peritonitis. There is nothing to be done. He dies on the fifth day, conscious for most of it, in the kind of pain that makes patients beg for something you cannot provide. His mother is in the corridor when you come out. She has been there most of the 5 days, sitting on a wooden bench outside the ward, not eating much, sleeping against the wall. She stands when she sees you. You tell her. She asks if he suffered. You tell her he was given morphia. This is true. It did not prevent the suffering. It reduced it, imperfectly, for intervals. You walk back through the ward. 40 beds. 38 occupied. The gas lamps are lit. The ward smells of carbolic now. Lister's methods have been in use here for 3 years, and the infection rates have dropped measurably, which is a genuine improvement, which the institution has adopted slowly, bureaucratically, with the particular resistance of systems that have been functioning a certain way for a long time. You walk the length of the ward. 12 of these men will be discharged improved. 4 will die. The rest will remain, in varying states, waiting. You have been doing this for 21 years. You are 43 years old. You look, your wife has told you, closer to 55. You stand at the end of the ward and you understand, with a clarity that has been approaching you for years, that the understanding changes nothing. The ward will be here tomorrow. The waiting list is 10 weeks now. A new dresser started on Monday, 22 years old, arrived from Leeds with a letter of introduction. You have not read the letter. You signed the intake form and handed it to the registrar. You retire in 1878, at 58. The retirement is not dramatic. There is a dinner at the hospital, attended by 12 colleagues, at which several speeches are made and a silver inkwell is presented. You thank them. You mean it. You return home. Within a year, a man named Whitmore takes your position. He is 34. He has trained partly under Lister, partly under Spencer Wells. His technique is cleaner than yours was at his age. He uses carbolic rigorously. His mortality rates are better than yours were at the same point. The ward does not notice the transition. The institution absorbs it, as it absorbs everything, quietly, procedurally, without ceremony. You live until 1891. You do not practice again. In your final years you read, mostly, natural history, theology, some novels. You take walks in the park near your house in the mornings. Eleanor is alive. Your son visits occasionally. You are not unhappy, precisely. You are quiet. There is a difference. Somewhere in the city, in a wooden amphitheater filled with sawdust and students, a man is being brought to the table. He is conscious. The surgeon is young, perhaps too young, but competent. The instruments are laid out. The students lean forward in the tiered seats. The surgeon raises his hand. The system continues. It was never really about you.